Well, let's get more analysis on this now from Dr JP Loughrey, who's Vice President of the Royal College of Emergency Medicine Scotland. Good morning to you, Dr Loughrey. Is that a picture that you're seeing right across Scotland? It's not just Edinburgh.
I think that's a really accurate representation of the pressures going on across every hospital in Scotland at the moment. Previously, smaller community hospitals, district general hospitals and children's hospitals wouldn't be immune from pressure, but they would perform very well against the 4-hour standards, and they wouldn't have the ultra-long waits that we're having just now. But right now, every hospital in Scotland is under the same pressure with these ultra-long waits, with patients with delayed discharges causing exit block in emergency departments.
Why is it so bad at the moment? We heard there that the average wait that day, I mean, and it is a single day snapshot that Lisa was doing, but that day the average wait for admission to hospital in A&E was 9 hours.
It's a combination of things. So we have 1 in 6 acute beds in Scotland now occupied by patients who have got a delayed discharge and a delayed transfer of care to the community because of problems and shortages in social care. We're now seeing some of the problems built up of staffing shortages because of the chronic conditions that we're having to work in under enormous pressure every day, which means actually there are large numbers of nursing and medical vacancies in emergency departments across, again, every department in Scotland. We're seeing an increasingly frail and vulnerable elderly group of patients presenting to emergency departments, and these are the patients who are least able to tolerate these excessive waits in emergency departments, and we know that there's an association with harm to these patients. I think the harm to staff has to be alerted here as well, because we won't have the staff to work in these conditions for very much longer.
Yeah, you mentioned the staffing issues there. The Health Secretary Humza Yousaf told us at the weekend, he said, "I've offered a record pay deal, one that is the single biggest pay deal ever offered to NHS staff in a single year in the history of devolution." Is pay at the heart of the issue, or are there other reasons why staff are leaving in such numbers?
I think it's difficult to say anything specifically about pay because it's a very broad and disparate topic. Consultant pay, junior doctor pay, and those staff members on Agenda for Change pay scales, all are paid and all are negotiating different pay deals just now. Right now, the problem is with the working conditions. These are staff in emergency departments dedicated to looking after patients with acute illness, emergency conditions for short periods of time. 95% of patients should be moved on within 4 hours, either admitted to hospital or discharged. We're now seeing 1 in 3 patients spending more than 4 hours. And data from Freedom of Information requests have shown that there's over 4,000 patients in 1 year spending more than a day in an emergency department. Having to work in these conditions means we can't provide the emergency care that we want to be able to. We're constantly having to look after 2 or 3 times the numbers of patients within our EDs than we should, and these aren't places where patients should spend long periods of time. They're noisy, they're overstimulating, and they're understaffed to look after that number of patients and that volume of acute illness.
JP, does it create problems within a hospital setting? I must think that the staff working in an A&E, do they look at other areas of the hospital and go, "What are you doing? We're absolutely snowed under here. You need to take the patients off us more quickly."
It's heartening to know that actually we are all in this together. We regularly meet with our colleagues in acute medicine, acute surgery, our colleagues in primary care, and we're all facing the same pressures. Acute medical units have got record numbers of admissions and pressures on them, and we know actually that everybody is working as hard as they can, and no one's coming to hospital to do a bad job. We do see at times this causes fractious conversations, and it does cause difficulties in interspecialty relations. That's purely a product of the conditions and the stress that we're all under working in them.
Yeah, I'm very conscious of the fact that we always look at the A&E figures as a way to that I suppose they're given out to us on a weekly basis. They illustrate the problems within the NHS. But do we need to take a much tougher look at the discharge figures? Because we heard there from the nurse in Lisa's piece, Michelle, saying that it's 100 times more difficult to get out of hospital than it is to get in. Do we need to start highlighting the other end of the process much more closely?
Definitely. The problems in emergency departments are a product of exit block. They're a product of not being able to get patients from emergency departments to inpatient beds quickly enough. I think we know of the problems with delayed discharges, and many hospital systems examine metrics such as pre-noon discharges because we know the patterns of attendance to emergency departments tend to be higher in the afternoon and evening. and creating capacity in anticipation of that means that you don't have 100 to 120 patients waiting in emergency departments.
But JP, it was ever thus. We've always known that there was problems with delayed discharges in hospitals. I'm just wondering, are there any countries doing this well, where they don't have this massive problem getting people back into their own homes?
No, I don't know of anywhere specifically that has this sorted. This seems to be a relatively widespread and worldwide problem within emergency departments, and I read stories from the United States and from Canada where they're experiencing a very similar picture. It's difficult to make comparisons between individual healthcare systems. We regularly hear that Scotland has the best performing emergency departments within the United Kingdom. That's all very well and good, but it's difficult to then justify saying to staff that things are okay when we have to look at those patients spending 12, 24, 48 hours in our emergency departments in very poor conditions.
The Scottish Government's currently looking at the introduction of a national care service to try and improve the situation for people leaving hospitals. Is that the way to deal with this, do you think?
Right now, for this winter, we need really urgent steps. We need an increase in the acute bed base and the acute capacity within the hospital system. Introducing a national care service may help to smooth out some of the wrinkles in the system and reduce the numbers of delayed discharges, but that won't help this winter. We need introduction of urgent measures just now to improve social care capacity and to improve the number of acute care beds that are available within our hospital systems for this very coming winter.
JP, thank you for your time this morning. Dr JP Loughrey there, Vice President of the Royal College of Emergency Medicine in Scotland.
It's 7:20.